Welcome everybody, my name is Bill Ortega with California State University San Bernardino. Today we're going to talk about malignant hyperthermia for our N660 Instructional Technology and Nursing Education. Here we go. Upon completion of this module, the learner will be able to identify at least one triggering agent of malignant hyperthermia, differentiate the roles and responsibilities of at least one team during the malignant hyperthermia crisis, identify the only known antidote for malignant hyperthermia and the initial dose that should be given, and list at least 2 methods for cooling the patient who is experiencing malignant hyperthermia. For the purposes of this presentation, I'll be now referring to malignant hyperthermia as simply MH. This is a long drawn out explanation of the pathophysiology of MH. However, the main takeaways from this, without having to dive too deep into the pathophysiology of this crisis, is to understand that the MH is typically an alteration in their calcium regulating mechanism. The trigger allows excessive calcium accumulations in the muscle cells, and in essence, calcium acts upon certain proteins that cause muscle to contract. Therefore, excessive calcium leads to sustained muscle contraction. Understanding that this enhanced metabolism can only be sustained for a short period of time, and therefore will begin to produce a lot of carbon dioxide, and in essence lead to cellular acidosis and eventually deplete the oxygen and ATP within the body. A change in anaerobic metabolism worsens, and the production of lactic acid increases. Therefore, the cell wall begins to break down and more potassium is released into the bloodstream, and this is where an individual will start to experience hyperkalemia and cardiac dysrhythmias. This is just a quick picture that demonstrates what I just explained in the previous slide. The sustained contraction generates more heat than the body is able to dissipate, with possible increases of 1 degree centigrade every few minutes. Okay, so here are a few of the triggering agents. In essence, you just need to remember inhaled general anesthetics for the most part, but the more important one being succinylcholine, in my opinion. Alright, so here, early signs include jaw spasms, increased end-tidal CO2, that's a hot one, you may want to remember that for your exam, unexplained persistent tachycardia, tachypnea, and of course, cyanosis. There's some literature that differs in some of these with regards to what are early signs and what late signs are. However, if you keep increased end-tidal CO2, you should be pretty good with regards to what early signs are, what to look out for during this crisis. Under late signs, however, which is the next slide here, so these include sweating, muscle rigidity, increased temp. There's often delayed increase in blood pressure, hot soda lime canister. Now, again, depending on what literature you're reading, will determine whether or not a late sign is truly a late sign. What I would mainly look out for here, and especially with the purposes of your exam, would be under muscle rigidity and end-tidal CO2. So anytime you see those two things, you're going to want to start determining whether or not you're experiencing an MH crisis. All right, further keys to consider: anyone receiving succinylcholine, as I mentioned earlier, is also a major triggering agent. Elevated CO2, like I talked about just a few slides ago, is the most reliable initial clinical sign indicating the development of acute MH. And muscle rigidity, like I explained earlier. Generalized muscle rigidity in the presence of neuromuscular blockade is considered pathogenomic for MH, provided other confirmed signs are present. Alright, so what do? We want to act fast. First and foremost, you're going to want to discontinue any of the triggering agents. You're going to want to call for help. You're going to need a lot of people helping, specifically because you're going to need to administer a lot of medication, a lot of dantrolene, and it takes some time to administer. Like I said, you're going to administer dantrolene. You're going to require 2 to 3 hours just to mix it alone, and then you're going to need a lot of ice for basically just to reduce the hypothermia. And you want this as soon as possible. Okay, so this is what your teams consist of. Your primary or circulating RN will record and delegate recording of events. Your dantrolene team, like I said, you're going to need 2 or 3 RNs to prepare and administer this medication quickly. Your medication teams, which is basically usually going to be someone from the pharmacy or the pharmacy group of people. Your cooling team, this is typically your ICU RN nurses. Um, Now, I say this because this is what's typical, and provided you have enough hands on deck, you can accommodate this. However, it's not a necessity, as any of the nurses and/or medical professionals can take up any one of these roles. All right, so with dantrolene, this is the only known antidote for malignant hyperthermia. It should be administered as a loading bolus of 2.5 milligrams per kilogram, given IV rapidly through a large bore IV line. The end tidal CO2 will generally return to normal as the dantrolene takes effects. In most cases, dantrolene reverses the acute hypermetabolic process within minutes. Dantrolene comes in 20 milligrams per bottle and is mixed in a 60 ml of sterile H2O. Only water. You have to shake vigorously until the solution is clear orange, and then status post initial dose may administer additional doses of 1 milligram per kilogram every 5 minutes to maximum of 10 milligrams per kilogram. The initial loading dose should be completely administered within 15 minutes from recognition of H. Okay, keep in mind that 25% mannitol, which is an osmotic diuretic, is used to help prevent renal failure, and dantrolene already contains mannitol within it. Also, we're going to do procainamide, which is 20 milligrams a minute and is administered to treat the cardiac dysrhythmias. And we got to watch carefully for hypotension, the widening of the QRS by 50%, and bradycardia. Calcium chloride or calcium gluconate, 2 to 5 milligrams per kilogram, is common treatment for serious hyperkalemia, and lidocaine or amiodarone are alternative medications for life-threatening dysrhythmias. This slide here is just a quick, real slide to show possible ways of cooling. You may or may not already know these, but in essence, to help with cooling measures, we're going to either use an A line, we're going to insert a rectal tube, we're going to start an NG tube, central venous catheters, and basically a Foley, so that we can monitor the input and output extremely accurately. Also, keeping in mind that the lavage for NG tube, rectal tube, or open body cavity, the ice packs should be applied to the the neck, axilas, and the groin. We're going to hydrate with iced IV fluids, and we're going to cover the patient with cold water soaked towels or a cooling blanket if you have it available. All right, a few complications that needed mentioning. Obviously, there are more, especially when you take into consideration cardiac events or cardiac dysrhythmias. However, these needed to be brought up primarily for the purposes of your examination. Therefore, let's look for acute renal failure, like we spoke about earlier with the brownish color, tea-colored urine. This basically indicates a presence of myoglobins within the urine. And DIC, disseminated intravascular coagulation. You're going to want to monitor temperature and laboratory results carefully. And in essence, do either one of these, you're going to want to monitor intake and output aggressively. So what do we want to look for? We're going to monitor for at least 72 hours. We're going to look for temperature. We're going to stop cooling when the temperature decreases to 101 degrees Fahrenheit or 38 degrees Celsius. We're going to monitor the blood pressure, and this should remain stable for patients from baseline. Monitor the urine output. Watch for development of cardiac instability manifested by tachycardia and dysrhythmias. Monitor labs and development of DIC and hyperkalemia, and watch for acute respiratory failure or ARDS. Okay, so in conclusion, MH is life-threatening crisis. It requires coordinated actions from many individuals that know what they're doing. The speed with which dantrolene is administered to the individual experiencing MH increases their survivability, and it is paramount that the hospital personnel caring for patients at risk have a high index of suspicion for the possibility of malignant hyperthermia. So just keep your eyes open. Always remember you're never alone. There's actually an association that's there to help you 24/7. So if ever in doubt, you need to reach out to the Malignant Hypothermia Association of the United States. And here's their references.